Let's continue here with the spirometer tracing, and please also take a look at the lab for this week and make sure that you understand what a tidal volume is. Let's start with that. So normal breathing in and out of your lungs, it's about 500 milliliters worth of air, and it's recorded on a spirometer tracing like this. So you're going in and out and normal breathing. So that will be tidal breathing. Tidal volume about 500 milliliters. Once you have taken a tidal breath out, you could breathe out more if you really wanted to. You could go all the way down to here and try to squeeze out every bit of air that's in your lungs. That volume that you can exhale above and beyond a normal tidal breath, that's called the expiratory reserve volume. Depending on your size, they have an average here of about 1100 milliliters. There's a certain volume of air that you cannot breathe out. As hard as you would try, you would have to kill yourself. You would have to collapse your lungs to get that amount of air out. And that's called the residual volume. So from here to here. And here your book puts it at 1200 milliliters. In the lab, we said roughly about a liter. So somewhere around that. And here we're going back into normal tidal breathing, and then here we are up. We just took a tidal breath in, but if we really wanted to, we could definitely breathe in some more. If we took our intercostal muscles and the sternocleidomastoids help, if we really wanted to, we could definitely breathe in some more. And that volume above and beyond a normal tidal breath that you can breathe in is called the inspiratory reserve volume. Inspiratory reserve volume. Depending on your size, it's considerable. It just varies quite a bit from person to person, but you could go all the way up to here. And for a pretty large sized person, and now you're all the way up here and your lungs are fully inflated, and that's the best you can do. They put here the volume at 5,800 milliliters. That's pretty big. So now if you are up here and you decide you want to get rid of all the air that's in your lungs as fast as possible and as much as possible, you would exhale, and that number from here to here, that is your vital capacity, and that's a very important diagnostic measure. So your vital capacity, it's put here and over here. Vital capacity, it's 4,600 milliliters on average. That's what they put right here. It's pretty big, actually. Now, if you're adding to the vital capacity the residual volume on top of that, then you're going to have the TLC, the total lung capacity. That's this one right here, total lung capacity. And one more number here, well, actually two. If you're adding the tidal volume plus the inspiratory reserve volume, then you have the inspiratory capacity. And if you are adding up the residual volume plus the expiratory reserve volume, then you have the functional residual capacity. So those are the last ones. So remember that we said in lab, a capacity is a compound of at least two volumes. And you can see this here very nicely. The functional residual capacity is the residual volume plus the expiratory reserve volume, or the vital capacity is composed of the inspiratory reserve, the expiratory reserve, and the tidal volume. So a capacity is always two or more volumes, and a single volume measurement, well, that's what you have here, the tidal volume or the expiratory reserve volume or the inspiratory reserve volume. So I think you got the idea. Now let's take a look at airflow. The flow, just like with the blood flow, the flow is proportional to the pressure. It's sort of the average pressure over the resistance. Some of you were having some trouble with this equation when we were doing blood flow last week. Same thing here. Basically picture it this way. If the resistance is minimal, then you really don't need to add much pressure in order to achieve a certain amount of flow. Or you can picture like a river. If the river bed is really wide, then you don't need to add much pressure to move a lot of water, get a lot of flow. But if the if there's a lot of resistance, that means we narrow down the pathway for the water to flow or the air to flow, then you need to have more pressure in order to produce the same flow. So anyway, so this is about the airflow here. A single respiratory cycle consists of one inspiration, 1 by 1 expiration. It is kind of like the cardiac cycle. So one full cycle of inspiration and expiration here. In the cardiac cycle, we had one full cycle of contraction and relaxation. And passive versus active expiration. Active means you're contracting like the diaphragm to get some air into your lungs. Passive means you're relaxing something or you don't actively do something. So let's take a look at how this works. When the diaphragm is relaxed, it takes this dome shape right there. And the space in your lungs, it's a certain volume that is there. Now you want to get air in. Now you flatten out the diaphragm, so you're taking it from the shape up here to down here. That means you now increase the space here. So now we are creating a low pressure system in the lungs right here. We have increased the volume. Watch from here, where you have this kind of angle right here. Now we're flattening everything out, and we definitely have increased the volume. When the volume increases, then you can either add more air or you're creating a low pressure system. So at first we're going to have a low pressure system, and that will, in this case, it will suck air into the lungs. So that's how you breathe in. And that's active because you need to contract the diaphragm. It's pretty much all flat right here. The air will go into the lungs because there's relatively low pressure. So now when you want to exhale, all you have to do is relax the diaphragm. It returns to its normal shape, this dome shape, and that decreases the volume here, and that will push the air back out. Now your book shows this analogy to a pump handle, where the movement of the handle on the hand pump is analogous to the lifting of the sternum of the ribs, and you can see this analogy right here. It is kind of a good comparison. And then here, basically here, the bucket handle motion increases lateral dimensions of the rib cage, so you can see this moving out. It's kind of like the same thing as a bucket handle. Anyway, so the pressure changes during quiet breathing. You might expect that it's a lot of, it's a very dramatic pressure change, but it really isn't. So we're going plus minus 3 millimeters of the mercury. That's basically it. So during normal quiet breathing, you're basically changing the interpleural pressure between -6 and -3 millimeters of the mercury, going back and forth. The volume of air moved, that's the normal tidal breathing, is about 500 milliliters. So we're going up and down, up and down. That's our tidal breathing, about 500 milliliters of air that are being moved. And the alveolar pressure, basically this oscillates between -1 and +1. So as we are increasing and decreasing the pressure in the air pressure in the lungs, we just have to make sure that as our muscles are working, like the diaphragm is pulling down and going back up, so it's going back and forth in this direction, changing the volume of air that's in the lungs. So we just need to make sure that the tissues that are lining here, the side walls of our lung, and then also the chest walls, and so these tissues that I have to slide past one another, we just need to make sure that they're always staying attached to one another, and that they're sliding past one another is friction free. So we need to have this elastic recoil of the chest wall, and we need to make sure that the pleural fluid keeps the lung tissue sort of attached to the chest wall. Now this works just fine if there is no hole in the system. If you were to create a hole here into the system, then of course external air would enter in, and it would basically collapse the air, and that's called a pneumothorax, and that's basically on our next slide. So here, hopefully this never happens to you. Hopefully you don't live in a neighborhood where stuff like that is common. So not a good idea to have a knife creating a hole to which air can go in from a different area than it normally should be. So air should be going in and out only here through the airways. But now you're creating a hole with this knife, and now air can come in here, and it's basically like popping a balloon. The lungs will collapse. This is life-threatening. If it were to happen on both sides of the lungs, that will be it. Some people, if you, let's say you get stabbed with a knife or maybe a gunshot wound to the lungs, they will maybe collapse one side of the lungs. You might be able to survive that, but it is called a pneumothorax. It is a life-threatening condition because it's just like popping a balloon. Your lungs will collapse. Now let's take a look at compliance versus elastance. Compliance is the ability to stretch. High compliance means it's easy to stretch. Low compliance means it requires more force. It's not so easy to stretch. And elastance or elasticity is the ability to return to a resting volume when the stretching force is released. So here we have the law of Laplace that I really don't want to spend much time on. You don't have to worry about any calculations around that, so that's not that important. Moving on to surfactant, we talked about that earlier. It just makes sure that you have minimal friction or sort of this labored breathing that would make it so hard to move these sheets of tissue past one another. Here's one thing to mention. The newborn respiratory distress syndrome comes from babies that have whose cells, the surfactant, the alveolar type 2 cells, they have not produced the surfactant, so inadequate surfactant concentrations, and now it makes it very difficult to slide these tissues past one another, and so now these babies have a hard time breathing, and that occurs in premature babies, preemies. So factors that will affect airway resistance. Here you have the factors listed: the length of the system, viscosity, diameter of the airways, and so you can take a look at this table. So now, these are two calculations that we also had in the lab. The total pulmonary ventilation is the respiratory rate or ventilation rate, how many breaths per minute you take, times the tidal volume. Here's an example given: 12 breaths per minute times 500 milliliters for tidal volume. That leads to a total pulmonary ventilation of 6,000 milliliters per minute, or 6 liters per minute. The alveolar ventilation, you need to subtract the anatomical dead space volume. So that means your respiratory rate or ventilation rate times the tidal volume corrected for the anatomical dead space. It's usually estimated at 150 milliliters, that anatomical dead space that does not participate in gas exchange. And so now our calculation leads to 12 breaths per minute times 500 minus the 150 milliliters of dead space that doesn't participate in gas exchange. Now we have to say our alveolar ventilation is at 4,200 milliliters per minute, and those are exactly the examples I used in the lab. So make sure that you can calculate this mostly for the lab. That will be relevant. And so here are the pressure changes that we see as we're breathing in and out. This image here is actually more complicated than what it needs to be. So we're doing tidal breathing. We're going between 2,200 milliliters and 2,700 milliliters, which is exactly 500 milliliters of tidal volume. And we're just going to put it in and breathe it out, and breathe it in and breathe it out. So exhalation gets us to 2,200, inhalation gets us back to 2,700. And you can take a look at the pressure differences. It's plus minus 3 millimeters of the mercury, and that's pretty much all you need to know. So here are some terms that are actually important. Eupnea is normal breathing. Hyperopnea is more breathing than normal, for example, during exercise. Hyperventilation is an increased respiratory rate without increased metabolism, such as in exercising. Now, hypoventilation is decreased breathing. Tachypnea is like panting, when you're breathing really shallow and really fast. Dyspnea is kind of a general term for abnormal breathing or difficulty breathing, and apnea is cessation of breathing. You stop breathing, as in sleep apnea. You're sleeping and you stop breathing for a moment.